A lot of the work that I do is with people with multiple chronic conditions. And the reason for that is that most of the time, when you look at older adults in particular, they don't have just one chronic condition. They have multiple chronic conditions. And then within that group, if we look at historically marginalized communities, they're more likely to have multiple chronic conditions earlier on, which then affect, of course, their quality of life in older age. And so the reasons behind them having early onset, if you will, chronic conditions like diabetes, hypertension, cancer, and other conditions is that it's this culmination, again, of the structural determinants of health as well as how they interact with the healthcare system. In the past, for health equity, we primarily focused on healthcare delivery, whether or not people had good access to high quality care. And as important as that is, a lot of the factors that contribute to the disparities that we see actually happen long before anyone comes into a clinic. It really is where you live, where you work, and how you live that influence your outcomes in terms of health. So in order to really make an impact, we have to not only focus on the healthcare system, but all of the other structural and systemic factors that contribute to these inequities. And so I'm really motivated by the idea of using research to better understand how policies influence different populations, particularly populations that have potentially been underserved in the past, but also to inform the design of policies that have the potential to not only improve healthcare for everyone, but importantly also to address some of these gaps in care for historically marginalized and underserved populations. My interest in health equity and policy actually started very early on when I was a kid. In my own family, I had family members who had health insurance either through Veterans Administration, Medicaid or Medicare, or Indian Health Service, whom I watched sort of deteriorate over time due to chronic conditions like diabetes and cancer and heart disease. They literally lost their eyesight, lost limbs through amputation, and had strokes. And watching this happen, I would ask the people around me sort of like, why is this happening? Like, why is this happening to this person? Don't they have a doctor? I don't understand. And what I was told at that time was, well, this was just what happens to us when we have diabetes, or this is just what happens to us when we get heart disease. And that struck me as fundamentally wrong, not even understanding the healthcare system, but I didn't understand how, if we supposedly have access to this care, why is it then that we get these outcomes that are so disproportionate and that we accept it? That we accept that this is just the way it is for us. And so that really stuck with me. I became very interested in policy from a very early age and decided very early on I really wanted to better understand public policy. And over time, I really gravitated towards health policy as an area where we had the potential to grow and innovate in terms of how we think about providing care, particularly in terms of addressing those gaps for different communities in terms of their ability to have better outcomes.